Welcome to PGOG Pathways to Growth in Obstetrics and Gynecology for Postgraduates and Consultants. Today's topic is uterine leiomyoma, must know areas with a question answer format. How do you classify leiomyomas? By FIGO abnormal uterine bleeding palm coin classification system, there are three subclassifications of leiomyoma which were introduced in 2011 and which have been modified in 2018. Primary classification is whether the leiomyoma is present or not. Secondary is dividing the leiomyomas as one group is leiomyoma submucus, that is SM, and another group is leiomyoma O is for others. So dividing the leiomyomas into either submucus or all the others are included in LO. Tertiary classification has total 0 to 8 varieties of leiomyoma, and there is another one which is called as a hybrid leiomyoma. Traditionally, leiomyomas were divided simply as submucous, intramural, subserous, cervical if the leiomyoma present in the cervical cervix, or rest of the extra uterines. This tertiary classification was modified in 2018. Here in 2011, the submucous variety had only three, that is type 0, type 1 and type 2, whereas by 2018 modification, submucous also includes type 3. So there are four types under the umbrella of submucous in by 2018 modifications. It is type 0, type 1, type 2 and type 3. Now here as we can see, type 0 is when it is a pedunculated submucous fibroid. Type 1 is presence of a submucous fibroid which has less than 50% of the component in the myometrium. So this is less than 50%. Type 2 is whenever the myometrial component is greater than or equal to 50%, then it is type 2. And type 3 is entirely in the myometrium, but it is just touching or abutting the endometrium. So there is actually no distortion of the cavity, but it is touching the endometrium, which has been brought under the umbrella of submucous by 2018 modification. Type 4, as we can see, is entirely in the myometrium. Now here to remember, after type 4, remember that these 5, 6 and 7 are mirror images of 0, 2, 1 and 0 respectively. So 1 as 0 as we know is pedunculated submucous. Here we have 7 as pedunculated subserous. 1 less than 50% in myometrium. We have 6 less than 50% in myometrium. 2 greater than or equal to 50% in myometrium. We have 5 as greater than or equal to 50% in myometrium. So that is why I have shown these yellow lines here so that it is easy to remember that 0 and 7 are having similarity. 1 and 6 are having similarity and 2 and 5 are also showing a similarity. Hybrid is the one which has, this is an example 2-5. So here the relationship of a myoma with the endometrium is described first, followed by its description related to the serosal surface. As here it is type 2 is greater than or equal to 50% in myometrium. Similarly, 5 is greater than equal to 50% in myometrium, but it is slightly bulging outside the serosal surface. So that is why this myoma is a large one, which is showing the characteristics of both 2 and 5. So here how it is described is a hybrid 2-5. Now there are other modifications under 2018. First is 3 included in submucous. Second is there is a guideline to differentiate between 0 and 1 and to differentiate between 7 and 6. Pedicle diameter should be less than or equal to 10% of the mean diameter of the leiomyoma to label it as either 0 for submucous pedunculated or 7 for subserous pedunculated fibroid. So mean diameter is 3 diameters are measured by ultrasonography or MRI by imaging. Mean of these 3 diameters is taken. Diameter of the pedicle is also measured. If diameter of the pedicle is less than 10% or less than or equal to 10%, it is categorized as either 0 or 7. If it is greater than 10%, it will be labeled as 1 or 6. So this is the second modification which has been introduced in 2018 by this palm coin classification system. Third is to differentiate between 4 and 5. USG or MRI should show serosal distortion, then only we label it as 5. Absence of serosal distortion or contour is smooth, then it is 4. So that is third, that to differentiate between 4 and 5, we have to focus by imaging on the serosal contour. Serosal distortion is necessary to classify a leiomyoma as 5. If absence of serosal distortion, it is categorized as type 4. Now, what is the clinical significance of this FIGO tertiary classification of leiomyomas? Why we keep on dividing them into minute categories as 0, 1, 2, 3 for submucous, 4 for intramural, again 5, 6, 7 for the subserous, and 8 for all the rest of the others. So what is the clinical significance? It helps to decide surgical approach, especially whenever we are planning myomectomy. Type 0, which is pedunculated submucous, hysteroscopic myomectomy is always possible. Whereas with type 1, it depends on the size. Size is less than 3 centimeters, or some guidelines consider it as less than 5 centimeters, then hysteroscopic myomectomy is possible. Size greater than 3 to 5 centimeters for type 1. Type 1 is, as I will repeat again, less than 50% of the leiomyoma is present in the myometrium. That is type 1, which is a submucous category. Now here the size is larger. It is greater than 3 to 5 centimeters. In that case, hysteroscopic removal is not advisable. For hysteroscopic removal, medical treatment needs to be given preoperatively, such as GNRH analogs, to reduce the size. Then only one can attempt hysteroscopic removal. Whereas for type 2, where the leiomyoma major content greater than 50%, greater than or equal to 50% is present in the myometrium, this type of leiomyoma removal by hysteroscopy needs a greater surgical skill, or greater hysteroscopic skill is required for type 2. Whereas from type 3, 4, 5, 6, 7, rest of all these should not be attempted hysteroscopically. These are to be myomectomy to be done abdominally, either with the help of laparoscopy or robotic surgery, or as an open surgery. Why leiomyomas lead to heavy menstrual bleeding is a favorite question which is asked so many times in the practical examination also, when you get a long case of AUB with a leiomyoma or fibroid uterus. First is with, especially with the presence of submucous fibroids, or with a multiple fibroids enlarged uterus, what it leads to is an increase in the surface area of the endometrium that leads to heavy menstrual bleeding. Second mechanism is, these are the possible mechanisms which have been explained or given in the various textbooks. Second is impaired myometrial contractility, so that because of the presence of leiomyoma, so that the vessels are not getting constricted, they do remain open for a longer time, which leads to heavy menstrual bleeding. Third is, number of blood vessels which are supplying the endometrium and myometrium increases because of the presence of the leiomyoma, and that is why the overall blood loss is more. Fourth is, this presence of leiomyoma increases the cytokines, and local inflammatory reaction is greater over the endometrium, which increases the bleeding. Fifth is there is a hormonal imbalance. There is hyperestrogenism. Estrogen progesterone balance is not present, and that also adds to the heavy menstrual bleeding, resulting in excessive bleeding. And the last is there's presence of leiomyoma impairs clotting. There is excessive fibrinolytic action inside the endometrial cavity, and that is why the impaired clotting is present, and the blood vessels are not getting close with the formation of clots, and that leads to prolonged and heavy menstrual bleeding. What is important to remember that whenever there is heavy menstrual bleeding in a case of leiomyoma, suppose a patient has got one or two leiomyomas, you do never jump to the conclusion that heavy menstrual bleeding is only because of leiomyoma. All the other causes of heavy menstrual bleeding are to be ruled out as given under the palm coin. So apart from L, whether there is an endometrial polyp, whether there is adenomyosis, because adenomyosis and leiomyoma, either this can be confused by while we are diagnosing, or there can be sometimes presence of both conditions in the same patient. The same patient has adenomyosis as well as leiomyoma. Whether there is endometrial or typical hyperplasia or malignancy leading to heavy menstrual bleeding needs to be ruled out by doing an endometrial biopsy. So many patients are having leiomyoma, but some degree of von Willebrand disease is also commonly contributing to the heavy menstrual bleeding. So AUBC also needs to be ruled out. Then whether it is in the perimenopausal age group and ovulation, which is the reason cause of this heavy menstrual bleeding with along with the leiomyoma. So it is not necessary that presence of fibroid itself is sufficient to consider that that is the cause of heavy menstrual bleeding. We need to rule out all the other causes, in short, which are given under the palm coin. And for that, I request the mm, viewers to visit AUB series that is available under this PGOG. And in that playlist, you will get how to differentiate between all these causes of abnormal uterine bleeding. What are the various diagnostic modalities to diagnose fibroid uterus? Ultrasonography is the first modality of choice, imaging modality. It is comparatively cheaper and easily available. Saline infusion sonography helps us to differentiate between endometrial pathologies, whether there is a submucous fibroid or endometrial polyp. Hysteroscopy mainly helps to again definitely rule out presence of a polyp, or sometimes there can be polyp and submucous fibroid coexisting, or endometrial hyperplasia also mimic sometimes, or malignancy also mimic sometimes as a submucous fibroid. So all for all these pathologies, hysteroscopy is the best modality. Along with diagnostic also, it helps us to take the endometrial biopsies also. And in specific conditions, we need to proceed with the second imaging modality of choice, that is MRI. What are the indications of MRI in case of a fibroid uterus requiring myomectomy or uterine artery embolization? So, in which what is the place of MRI? Especially whenever we are planning a myomectomy, or we are considering the modality of treatment as uterine artery embolization, how MRI helps us? It helps us in fibroid mapping whenever there is a presence of multiple fibroids. So preoperatively only we know how many are intramural, how many are submucous, how many are subserous, and which are in proximity to each other, so that while performing the surgery, we do not miss out and there is complete removal of all the leiomyomas. That is fibroid mapping. Then it helps us to differentiate between adenomyosis and fibroid. Adenomyosis, where there will be, there is usually a presence of diffuse lesion, and except in adenomyoma, where it is sometimes difficult, but thickened endometrial myometrial interface is which is especially greater than 12 to 15 millimeter, is highly suggestive of adenomyosis by MRI. Then in some cases, MRI might help us to suspect that it is a leiomyosarcoma. Though it is not always possible to diagnose leiomyosarcoma by MRI, in some patients, it helps us to uh, increase our suspicion about leiomyosarcoma. And last is whenever we want to do uterine artery embolization, MRI helps us to identify a vessel which is feeding the fibroid. And these are the four indications or advantages of doing MRI in these patients where conservative uterine conserving treatment modalities we are considering. Can leiomyosarcoma be diagnosed preoperatively? It is not always possible. Unfortunately, with the best of the diagnostic modalities which are usually available, it is not always possible to suspect leiomyosarcoma because the size is not giving us an idea. Even a large leiomyoma might be absolutely benign, and a small one might be having a leiomyosarcoma spreading very fast. Ultrasonography unfortunately gives the same findings whether it is a leiomyoma or leiomyosarcoma. A rapid increase in size, which is defined as increase in the size of greater than 6 weeks in a year, in premenopausal women has low specificity. Rapid growth in postmenopausal women is highly suggestive of leiomyosarcoma, but before menopause it has low specificity. LDH and CA125 have low sensitivity and specificity to identify cases of leiomyosarcoma. Endometrial biopsy might help. It has been seen by studies that in 60% of the cases of leiomyosarcoma, endometrial biopsy help in identifying the presence of atypical or malignant cells. CT and MRI are comparatively better than ultrasonography, but still there is a limitation. It is not helping us in all cases to diagnose leiomyosarcoma. This GD-DTPA MRI, that is gadolinium enhanced MRI, it is showing a promise and it is emerging as investigation of choice mainly whenever we are suspecting that patient might be having leiomyosarcoma. So what are the features which are suggestive of leiomyosarcoma? There will be a rapid growth in postmenopausal women. Patient postmenopausal woman presenting with postmenopausal bleeding with a fibroid. Patient presents with pain, and if on whenever we are operating, how we suspect is the leiomyosarcoma has a softer consistency with a absence of whorled appearance on butt section. It has a variegated appearance and presence of, it is a very fast growing tumor, so that presence of necrotic areas also is quite larger, and that it changes the consistency from firm in leiomyoma to soft in leiomyosarcoma. Why should leiomyosarcoma be diagnosed preoperatively? Why we are discussing so much about how can whether we can detect leiomyosarcoma preoperatively before histopathology, before removal of the tumor and sending it up for histopathology? Can we uh, diagnose it? Unfortunately, we are not able to with the present modalities. But leiomyosarcoma, it is present in 0.05 to 0.09% of all leiomyomas. Conservative treatment. Suppose we are not suspecting leiomyosarcoma and we plan a conservative treatment, it will lead to the delay in the diagnosis of leiomyosarcoma, and that itself will change the prognosis. It will lead to shorter 5-year survival rate. Conservative treatments such as myomectomy, uterine artery embolization, MRI guided transcutaneous focused ultrasonography, if all these are being tried where we want to conserve the uterus, all this will lead to faster spread of the leiomyosarcoma. Third is whenever morcellation is done, especially during laparoscopy, in unsuspected cases of leiomyosarcoma, this morcellation itself leads to the this tissue being thrown all over the peritoneal cavity, and that leads to the upstaging of the disease. This is the most dangerous way of, even if though it is leiomyosarcomas are not very common, but if it is morcellation is done during laparoscopy in a case of leiomyosarcoma, it there is a possibility that it can upstage the disease, and that is the reason there is the importance of suspecting leiomyosarcoma preoperatively. What is the differential diagnosis of fibroid uterus and how will you differentiate between various conditions? First is adenomyosis, which can be, as I said, adenomyosis and leiomyoma, especially intramural fibroids, and ultrasonography as well as MRI will help. And in AUB, this palm coin AUB2, I have given all the features of adenomyosis by which we can differentiate ultrasonographically also between adenomyosis and fibroid. So again, my request is to go to AUB playlist, especially AUB2, where palm coin classification system and how to differentiate between these various pathologies I have already discussed. Now, ovarian masses and adnexal masses, especially in a PID, there can be a tubo-ovarian abscess. These can be confused with a subserous fibroid, and for this, clinically, we can differentiate as movement of the cervix will be transmitted to a subserous fibroid, and but not to the ovarian or to the tubo-ovarian mass, adnexal mass. Clinically, we can differentiate, and by ultrasonography imaging also, it can help us to differentiate between these conditions as ovarian mass and subserous fibroid and adnexal mass, for example, tubo-ovarian abscess in a case of pelvic inflammatory disease and subserous fibroid. Then for endometrial polyp, differential diagnosis will be for submucous fibroid, and for that saline infusion sonography, by which we are opening up the endometrial cavity so that it helps us to differentiate between endometrial pathologies, and by hysteroscopy we can differentiate between these conditions. Now, whenever there is a this pedunculated submucous fibroid, and if it is coming out of the cervix in the vagina, in that case, it is sometimes difficult to differentiate between this chronic inversion. In chronic inversion, also fundus is getting drawn out. So, chronic inversion and this pedunculated submucous fibroid, fibroid polyp, sometimes can be difficult to differentiate. But clinically, we introduce uterine sound, and sounding will help us so that if it is a inversion, then the uterocervical length will be shortened. Similarly, by ultrasonography and MRI, we can see the cupping, fundal cupping, whenever there is a inversion. Now, sometimes there can be a fibroid submucous fibroid, pedunculated submucous fibroid emerging from the fundus. As it comes down, it can drag the fundus, and there can be a combination of these two, that fibroid polyp can be associated with a chronic inversion, and in that these cases sounding as well as imaging will help us to identify the inversion. Imaging will show a contour of the fundus which has changed from convex like that to a like cup. It is called as fundal cupping. Pregnancy related conditions such as gestational trophoblastic tumor, identiform mole, or ectopic pregnancy with adnexal mass also sometimes need to be differentiated from various types of fibroid, and pregnancy test will be of great help in that, because both this fibroid is a disease of reproductive age group. So always we need to consider the pregnancy related conditions whenever there is a doubt about diagnosis. And endometrial cancer needs to be ruled out whenever there is a persistent anovulation in a case of fibroid by doing a endometrial biopsy. What are the effects of fibroid on pregnancy, and what are the effects of pregnancy on fibroid? So, how fibroid affects pregnancy? It is given that fibroid is rarely adversely affecting the pregnancy. If there is a retroplacental fibroid, it can lead to abruption. Placenta previa, PROM, PPH, malpresentations, all these are the risk increases with the presence of fibroids. Caesarean section rate increases whenever there is a fibroid complicating pregnancy. Rarely, in a post myomectomy case, there can be a uterine rupture, and especially it has been seen that whenever laparoscopic myomectomy is done, And if single layer closure is done and excessive use of electrocautery for the hemostasis is used while doing laparoscopic myomectomy, that increases the risk of uterine rupture in subsequent pregnancy. Effects of pregnancy on fibroid. Increase in the fibroid size is not seen in the majority. It is almost in 70% of the cases the size of the fibroid remains same, whereas in remaining 30% there can be increase in the fibroid size. Fibroid degeneration, as it has been traditionally described, that red degeneration of the fibroid is commonly seen during pregnancy. It is a rare complication seen in only 5% of the cases of fibroid complicating pregnancy. Patient presents with severe pain, and we need to differentiate it from all the other causes of acute pain in abdomen during pregnancy, as conservative management is the modality of treatment for this fibroid degeneration during pregnancy. What are the peculiarities of submucous fibroid? It is the most symptomatic. It can become infected. It needs to be differentiated from endometrial polyps, endometrial hyperplasia, or endometrial carcinoma, endometrial pathologies. It can be removed hysteroscopically if the size is less than 3 to 5 centimeter, and it is either type 0, that is pedunculated submucus, or type 1, where the myometrial component is less than 50%. This fibroid can lead to infertility or recurrent pregnancy loss by distorting the uterine cavity. What are the various treatment modalities? If you are asked, what are the various treatment modalities for treatment of leiomyoma? First is expectant management, which is usually considered when it is a asymptomatic fibroid and a woman is nearing menopause, because it is seen that postmenopausally, with the fall in estrogen level, the fibroid usually reduces in size and remains asymptomatic throughout the postmenopausal life, and that is the reason expectant management can be uh, uh, advocated for perimenopausal women with especially with a asymptomatic fibroid. Medical management, whenever woman is nearing menopause, again with the hope that once menopause occurs, the fibroid will become asymptomatic, especially when the mild symptoms are present. And for preoperative anemia correction, medical management helps a lot. Hysteroscopic myomectomy for type 0 and small type 1, laparoscopic myomectomy, hysterectomy, either vaginal, laparoscopic, or open, uterine artery embolization for uterine conservation, especially when the patient is not desiring future fertility but wants to conserve the uterus. Focus ultrasound, MRI guided focus ultrasonography. It is especially for those who want to retain the uterus as well as who desire future fertility. What are the indications of surgery in cases of asymptomatic leiomyomas? There are three groups for that. First is in patients who are having infertility or recurrent pregnancy loss, provided, this is most important, other factors for infertility or RPL are identified, treated, and or ruled out, and myoma should be distorting the endometrial cavity. If it is only intramural or subserous, then it should not be touched. It should not be operated even if patient has infertility or recurrent pregnancy loss. It should be distorting the endometrial cavity, and all the other factors for infertility and RPL are to be ruled out. Then only myomectomy should be considered. Whenever there is a suspected leiomyosarcoma, it is an indication to do the surgery even in a patient of asymptomatic leiomyoma, such as sudden increase in the size in postmenopausal age group, or endometrial biopsy showing cellular urtypia, or MRI is suggestive of leiomyosarcoma. Leiomyosarcoma is a fast growing malignancy which needs to be uh, surgically treated at the earliest. And whenever leiomyoma is leading to ureteric compression and hydronephrosis. These are the three indications for surgery in an asymptomatic leiomyoma. What are the various ways of performing myomectomy? We can do laparoscopic, where extracorporeal morcellation with containment bag use is the current recommendation or addition to the laparoscopic myomectomy to reduce the risk in unsuspected leiomyosarcoma. So what is used is a containment bag, and in that bag morcellation is done, which is called as extracorporeal morcellation. Hysteroscopic myomectomy can be done, as we have already seen, type 0 or a small type 1 or type 2 only in skilled hands, where the uh, myometrial component is greater than or equal to 50%. Laparotomy, where size is larger, greater than 10 centimeters, or the number of fibroids is multiple, more than 4 has been given in the textbooks. Vaginal myomectomy can be done in selected cases. Robotic myomectomy is nowadays is being done by robotic surgeons, or myomectomy can be done along with cesarean section. There are so many case reports and it is safe in expert hands. What are the various measures to reduce intraoperative blood loss or need of blood transfusion in myomectomy? Preoperative correction of anemia is important. Preoperative use of GnRH analogs to correct anemia. That the indication is to use it for 3 months around shorter duration for correction of anemia. Intramyometrial vasopressin infiltration is advocated strongly, where the vasopressin is infiltrated. Dilute vasopressin is infiltrated. 20 units is added to 200 ml of normal saline and it is infiltrated or around the leiomyoma. That leads to the vasoconstriction and reduction in the intraoperative blood loss. In laparotomy, use of Boni's myomectomy clamp. If it is not available, then to use the Foley's catheter, tourniquet or sutures can be tied around the uterine vessels and the infundibulopelvic ligaments to reduce the blood loss. Or there are special laparoscopic clamps are also now available, which can be introduced through the ports, and these are also temporarily or clamping the uterine vessels. Laparoscopic myomectomy itself is associated with less blood loss as compared to open myomectomy. So that is also one of the way of measure of reducing the intraoperative blood loss. Drugs which are shown to be of not of great use to reduce the blood loss are tranexamic acid, vaginal misoprostol, intramyometrial bupivacaine or epinephrine, and intravenous ascorbic acid. What are the pros and cons of using GnRH agonist preoperatively for myomectomy? Advantages are it helps in anemia correction is the most important advantage. By reducing the uterine size, transverse incision is possible rather than a vertical incision. While if we want to do open myomectomy, or sometimes we can convert the root also from abdominal to vaginal, and it is associated with reduction in intraoperative blood loss. But these important disadvantages are small myomas are not identified if we use the GnRH agonist preoperatively. These small myomas regrow postoperatively so that there is increase in the recurrence rate. And it is associated with important side effects such as hot flashes, and if given for greater than 6 months, it leads to osteoporosis, and the drugs are expensive. What are the principles of myomectomy? Incision should preferably be given over the anterior uterine surface, as posterior incision might lead to the adhesions postoperatively with a fixed retroversion of the uterus, reducing the fertility. Number of incisions should be kept as less as possible. Closure of the incisions after removal of myoma should be done as multi-layered closure to reduce the risk of uterine rupture with a future pregnancy. Then all the measures to reduce the blood loss are to be used, such as use of vasopressin, uterine artery clamping, or infundibulopelvic ligament clamping, and less use of cautery for hemostasis. It is better to do the hemostasis by using the sutures, as cautery will lead to more tissue damage and weakened scar. Myomectomy scar will be weak. What are the complications of myomectomy? Hemorrhagic shock is most important. Postoperative infection can occur. Uterine rupture can occur in subsequent pregnancy. It can lead to pelvic adhesions, reducing future fertility. The recurrence of fibroids and need for surgery in future is seen in around 10 to 15% of the patients undergoing myomectomy. That needs to be explained to a woman preoperatively, and accordingly consent should be taken. What are the various non-surgical treatment modalities for leiomyomas? Tranexamic acid can be used. It is effective in reducing the bleeding in women with heavy menstrual bleeding. OC pills can be used even with presence of estrogen. There is no increase in the size of leiomyoma. LNG IUS is a great alternative as a treatment modality. It is specially indicated whenever the size of leiomyoma is less than 3 centimeters and these are not distorting the uterine cavity. This is as per the NICE 2020 guideline that specifically there is a place for use of LNG-IUS in patients with leiomyoma, provided it is not distorting the uterine cavity and size is less than 3 centimeters. Progestogens, progesterone only contraceptives also can be used for the control of heavy menstrual bleeding. Mifepristone is progesterone antagonist, or some textbooks mention it as selective progesterone receptor modulator. It can be given, but risk of endometrial hyperplasia is there with a prolonged use because it is mainly progesterone antagonist. So estrogen will be acting on the endometrium with unopposed action of progesterone. So that the risk of endometrial hyperplasia is more. And so that is the reason mifepristone can be used only for a short term can be used as a drug for short-term use. Non-surgical newer treatment modalities for leiomyomas are GNR agonists can be used, and especially if these are to be used for greater than 3 to 6 months, then estrogen progesterone Addback therapies should be given. About GnRH use and agonists, antagonists, all the GnRH analogs as well as Addback therapy, I have explained it in detail in the management of endometriosis. So for this topic, I will advise the especially all the students as well as consultants to also go through AUB and endometriosis. These videos are available on PGOG. GnRH agonists are to be given for preoperative correction of anemia for a short duration, for reducing the size to change the root or change the incision from vertical to transverse. Perimenopausally, it can be given for 3 to 6 months with the hope that it can completely avoid the surgery once the patient woman enters into the menopause. Surgery can be avoided altogether. Oral GnRH antagonist, it is a new emerging option, newer treatment. The advantages, these are oral, whereas all the GnRH agonists are either intramuscular or subcutaneous. These can be given for a longer duration, up to 2 years, but Addback therapy should be given. Estrogen progesterone Addback therapy is to be given. Advantage is it has no flare up. With GnRH agonist, there is an initial flare up for 3 months usually is seen, which is not observed with the GnRH antagonist. About flare up also I have discussed in detail in the video on management of endometriosis, about in detail about the GnRH agonist versus antagonist. So it is a new option. The drugs which are used, oral drugs, are relugolix or elagolix. Ulipristal acetate is a selective progesterone receptor modulator which is usually given as with a dose of 5 mg per day. Can be given from 5 to 10 mg. It is usually given in cycles of 12 to 13 weeks, and such 4 cycles can be given. These are to be given intermittently again to avoid endometrial hyperplasia. Liver toxicity, some women are prone for that, and that is the reason liver function tests are to be done whenever monitored whenever we are giving ulipristal. Its mechanism of action, it leads to apoptosis and reduction in the size of fibroid as well as reduction in heavy menstrual bleeding. Intermittent use is advocated to avoid endometrial hyperplasia. Osteoporosis is not seen. That is its advantage when we compare it with GnRH agonist or antagonist therapy. Newer and experimental treatment modalities are gene therapy and molecular targeting. This is emerging, but it is still under experimental domain. Tissue engineering and regeneration for uterine repair after myomectomy. High intensity focus electromagnetic high FM therapy and combination therapies such as using GNRH analogs along or uterine artery embolization so that there is reduction in the size of fibroid followed by hysteroscopic removal. What are the conservative surgical options to treat myomas? If this question is asked, myomectomy, but we need to explain that risk of recurrence of fibroids or repeat surgery is around 10 to 15%. Uterine artery embolization is effective in 75% of the case women who fit for the indication of this conservative surgical modality. It is better whenever woman is not desiring fertility in future but wants to retain uterus. Reintervention rate is greater with UAE as compared to myomectomy. MRI guided focused ultrasound surgery, MRG FUS. It is thermoablative technique. It is better whenever a woman wants to preserve uterus as well as fertility. What is necessary is there should not be bladder or bowel should not be interposing between the different myomas. That means myoma should be near the abdominal wall without interposing of the bowel or bladder, and preferably it should be of a smaller size, less than 10 centimeters. Number also should be less than 4 and it should have a good vascularity. Then only this treatment option will be effective. Laparoscopic radio frequency ablation is another newer modality, but it needs special training as well as special equipment. Why cervical fibroids are considered as a surgical challenge and how to overcome it, the challenges are it leads to altered anatomy. Pelvic anatomy completely changes so that the ureters and uterine vessels are all in proximity to the adnexa, in proximity to the uh, upper border of the broad ligament. So much of change in the anatomy is there, and a surgeon should be aware of that. Risk of ureteric and bladder injury is greater if surgeon is not aware of the altered anatomy. Ureteric stenting might prevent ureteric injury. Uterine arteries are to be clamped and ligated before attempting myomectomy in a cervical fibroid. Which route of hysterectomy should be selected or you will select in a case of multiple fibroids with a size of uterus around 12 weeks? It depends on surgeon's training. Vaginal hysterectomy is preferred. It is the least invasive of all the types of hysterectomies, and we can do the volume reducing measures such as myomectomy, bisection, or coring, which I have explained in the video of vaginal hysterectomy available on PGOG. So three videos I think you should be visiting here to understand better this topic of leiomyoma. First is AUB2, that is Palm-Coin classification system. Second is to understand GNRH, management of endometriosis. And third is vaginal hysterectomy. Laparoscopic hysterectomy, where extracorporeal morcellation is done, we have already seen in the previous slide in the containment bag to avoid the spread in an unsuspected leiomyosarcoma. And we can do the open total abdominal hysterectomy. How will you manage a case of AUBLO with the presence of a 3 by 3 centimeter intramural fibroid in a 45-year-old woman? Endometrial biopsy to be done to rule out malignancy. Medical management of AUBO, that is iron ovulation, to be done by tranexamic acid, OC pills, or progestogens. It is not a direct indication for hysterectomy because when both are present and intramural fibroid is less likely to be the component leading to heavy menstrual bleeding. LNG IUS is a good option for this woman as it patient it is approaching likely to enter into menopause. GNRH agonist or ulipristal for 3 to 6 months is a good option as woman is nearing menopause. These are the references: Novak's and Tieland's gynecology, ACOG, NICE guideline, and FOXY guidelines. Thank you so much.